right, class, today we are going to talk about, we're going to begin our cardiology series, and specifically we're going to be talking about, I'm going through the Wall-Raven slides because I think that it kind of explains it a little better, but I'm going to mix these along with the Bledsoe slides to where you guys can see a different look at the same material, and hopefully something will stick and will stay with you. We're going to talk about the electrophysiology of the heart. Electro meaning, of course, the electrical part, the physiology, the function of it. And that's what we're going to do with this. And again, remember that an EKG, it is a graphical representation of the electrical activity of the heart. It's putting it into objective form so that we can monitor it, we can view it, we can dissect it, if you will. And that's what we're going to do with this. And remember, though, this is so very important to remember, that an EKG reflects the electrical activity of the heart. It does not represent mechanical function, okay? You got to have a blood pressure, you got to have pulses to evaluate mechanical function. You got an ultrasound, you could use that to see if it was actually squeezing. But even then, if it's squeezing, it doesn't necessarily mean that it's producing a pulse. And it's so very important to remember that fact. And remember that it tells us about electrical function. And again, but in order to understand the rhythm disturbances or a conduction problem, you got to understand what the normal is. And we're going to talk about normal as we go through. So that's what we'll be learning first. EKGs, they do not tell us about mechanical function. If you've got a hole in the heart and the blood's pumping out of that hole, again, well, I got a great EKG complex. Yeah, well, it's squirting out into the chest cavity. If there's a perfusion disorder, it doesn't tell us that. If there's not enough fluid in the pipes, if the pipes are too big, it's kind of a septic patient situation. These are all things that the EKG doesn't tell us. So you got to know what your tool tells you what you're doing. Now, our resting heart rate, again, and for those of you that have not watched the Fun with Physiology videos yet, you really need to watch those because they do explain it. So the ready state of the cell is, again, the potassium, the borrow the schoolhouse mentality, the potassium's inside the school, the sodium's outside the school, the bus shows up, applies an electrical charge, which then has sodium going into the cell, activating what the cell does, and then having potassium go outside of the cell. Sorry, guys. So it goes outside the cell, and again, it takes energy to return this to a normal state. And of course, we call that the recovery stage, okay? So polarization is that initial electrical impulse that causes the physiologic response. Depolarization is the actual switching, and then repolarization, again, is the recovery state. Again, that polarized state means it's ready to go. Depolarization, it gets the electrical shock, and then it goes from there, and then it resets itself. Okay? And again, through the electrical conduction of the heart, sinoatrial node goes through the intranodal pathways, which causes the atria to squeeze. It causes those atria to squeeze down. The electrical signals collect at the AV junction. And when it collects at the AV junction actually slows it down just a teeny bit. And the reason that it slows it down is to allow the ventricles time to fill. The muscle stretches out. It's primed, ready to go. Starling's law is in effect here. It's going to push out with more force when it's filled up. And then again, from the AV node, it goes through the bundle of His, and then into the left and right bundle branches, in which case it ends up in the Purkinje fibers, which will then trigger the electrical response of the heart. It depolarizes. That will mean the ventricles then squeeze, okay? Now, our inherent rates, and these are important to know, because when we start looking at rules and we start looking at problems and abnormalities that we might have, this is the one that we're probably going to be looking at the most. So sinus node beats at 60 to 100 beats a minute. AV node 40 to 60. The ventricles, it depends on which book you read. There's some that say 15 to 40, some that say 20 to 40. The actual muscle themselves is about 10. Okay, so again, and this usually gives you your agonal rhythms. Usually a sinus node rhythm is going to be a narrow complex. Usually an AV junction rhythm is going to be a narrow complex. If I go back up to here, again, the signals are propagating from here, which means that it's all in tune, it's all in sync, and all of this electrical function is usually working, in which case you have a nice narrow complex. If you've got a signal that's starting from down in this area, it has to work all the way backwards, and unfortunately that takes a whole lot longer, which is when you get this wide complex, okay? So your ventricular, by the way, you can get wide complexes from either it originates from down here, or if the signal comes from here but has to go around a damaged area. Somewhere usually in this left or right bundle is where that happens. And if they're having to go around it, it makes it wider, okay? So that sometimes is a little tricky to figure out. Is it starting from the atria? Is it starting from the ventricle? And on our wide rhythms, then we got to do a little bit more investigation, okay? Which is why it's so important that we understand our waves and where they come from and the rules that apply to each of these. Now, pacemaker sites, the fastest one usually is the one that takes the lead, okay? So again, if we got a sinus node, it's probably going to be your primary pacemaker, but you can have the backup pacemakers of the AV junction and then the backup pacemaker of the ventricles, the Purkinje fibers themselves. Again, irritability. So one of the cool things about cardiac tissue is that it irritates very easily. It is able to create its own electrical impulse. Matter of fact, when it doesn't get oxygen, it gets really torqued off. It says, hey, I need to beat. And it beats. And again, it creates its own electrical impulse to do that. But usually the guy that's making the most noise, as far it will be the one that maintains the pacemaker. But the irritability can override the higher pacemaker site. And it's really important to understand, especially if something's touching it. Maybe a stent gets loose and is touching the muscle. That's another good reason. If something is actually, if the muscle is bruised, again, all of these things can cause irritability. This escape mechanism, if you slow down too slow, the lower pacemaking site is going to resume responsibility. It knows that it needs to do something, and it's going to start doing it, okay? So these are escape mechanisms, and it's there to keep us alive. It's not there to keep us alive forever, but it's there to keep us alive. Now, again, how is the SA node controlled? Okay, the SA node is controlled by the autonomic nervous system, very specifically the sympathetic and parasympathetic branches of the autonomic nervous system. Sympathetic, fight and flight. Parasympathetic, rest and digest. So we have to understand that again, that's what speeds up the SA node, and then the parasympathetic slows it down, okay? So there's some physiological reasons for this, okay? When there's a high demand, again, you expend a lot of energy, and that parasympathetic allows us time to rest in order to replenish those energy stores. All right, that's going to do it for the electrophysiology, and I'm going to see you guys on the next one.